So we will be moving on to the symposium on obesity. May I request Chairperson Professor Noor Shafina to be on the dais, please. Madam is Associate Professor from University Teknologi Mara, Malaysia. Her areas of interest is pediatric obesity, diabetes mellitus, and endocrine disrupting chemicals. The second chairperson for the session is Dr. P.S.N. Menon. Sir is former sub-dean, professor of pediatrics, officer in charge, pediatric endocrinology and genetics division, former consultant and chairperson, and past president of ISPE. So, Sir has worked in AIIMS New Delhi, Jabbar Al Ahmed Armed Forces Hospital, Ministry of Defense, Kuwait, and Indian Society for Pediatric and Adolescent Endocrinology, editor-in-chief of Journal of Pediatric Endocrinology and Diabetes. His areas of interest is growth and puberty and DSD. May I request the chairpersons to introduce the first speaker and start the session. Thank you.
Thank you. Thank you so much. Good morning and salam to all the delegates. Welcome to our first symposium for the second day of our EPAS 2024 conference. Prof. Menon and I will be chairing the session this morning. This is the Obesity Symposium. We have 3 esteemed speakers that will be sharing their knowledge as well as their experiences with us this morning. Just to remind all the delegates that the Q&A will be at the end of the session. So just keep your Q&A to the end. And allow me to introduce the first speaker, none other Professor Lee Yong Seng, who is currently the Group Chief Pediatrics at the NUH Singapore. He's also the Co-Director of National University Centre for Women and Children at the National University Health System. Prof. Lee is also the head at the Khoo Teck Puat National University Children's Medical Institute, NUH. He's the head of the Department of Pediatrics at the NUH. He's the head of professor at the Department of Pediatrics, Yong Lu Lin School of Medicine, NUS, as well as the Deputy Director, Translational Research Program at the NUS as well. So I think he definitely has a endless list of publications and research works. Without further ado, I would like to invite Prof. Lee to speak on the approach to management of childhood obesity. The floor is yours, Prof.
Thank you for the kind introduction. Thank you, everyone. So I've been tasked I'd like to thank the organizers for the invitation. And today I've been tasked to discuss about the approach and the management of childhood obesity. These are my disclosures. So in the last few years, we've seen advances in the molecular genetics, which have helped us to make easier to make diagnosis of syndromic and monogenic obesity. And now we have a new arsenal of anti-obesity medications for adolescents with obesity, and it was advocated by the recent AAP's clinical practice guidelines for childhood obesity. So this actually would prompt a paradigm shift in the way we diagnose and manage our children with obesity. And this is particularly important in Asia, which will be worst hit by the childhood obesity problem. So what are our duty to our obese children when they come to our clinic? There are 3 things that we have to do. First, decide, is this just common obesity or this is pathogenic obesity, like Cushing syndrome? The second thing we have to do was to diagnose and manage the obesity-related complications like type 2 diabetes mellitus. And thirdly, institute evidence-based weight management strategy. So fortunately, the vast majority of the children that comes to our clinic have common obesity due to sedentary lifestyle and undesirable feeding habits. But a small number of them might have pathological obesity due to endocrinopathies like Cushing syndrome, hypothyroidism, hypopituitarism, genetic conditions like Prader-Willi syndrome, Bardet-Biedl syndrome, and monogenic forms of obesity, as well as patients who have a craniopharyngioma, post-operative, or hypothalamic obesity. So how do we approach and navigate this in our busy clinic. Most of the children with common obesity are usually taller than their peers because of overnutrition. And many of these conditions that result in pathologies with an obese phenotype results in poor height velocity and short stature. So perhaps we can use this in our approach when we see our patients in the clinic. So this is one particular approach that you can consider. So first of all, is the child short? The height is below the 50th percentile, below the mid-parental height range, or just have a slow height velocity? If so, then perhaps consider the pathological causes. Look out for the red flags. Are there Cushingoid features, hyperthyroid features, delayed bone age, so suggest Cushing syndrome or hypothyroidism? Is there any pubertal delay, developmental delay, neurological issues, abnormal visions, consanguinity and dysmorphism, and early onset obesity suggests syndromic or monogenic obesity? And then you investigate accordingly. But of course, if the child is not short and there's no developmental delay or extreme obesity by 2 or 3 years old, do consider then common obesity, and then you go ahead to assess the patient's diet, exercise, family history, as well as assess them for complications associated with obesity. And this is another article that I got it from another article, and it's further distilled what we have discussed, and I find it quite useful, and perhaps you can consider this approach. First of all, assess any medications that might have predisposed a child to obesity, and if not, if there's an impaired growth velocity, or there's any CNS symptoms, consider endocrine evaluation, check the patient's thyroid level, cortisol levels, and growth hormone stimulation tests. If there's any intellectual disability, consider conditions like Prader-Willi syndrome and Bardet-Biedl syndrome. And of course, if there's early onset obesity before 3 years of age with hyperphagia, you can assess the leptin levels. And if they are low, consider leptin deficiency. If not, consider all the various other forms of monogenic obesity, which I'll cover a bit more later on. And of course, there's a third approach that you may want to consider. From the medical genetics point of view, you can classify them into 2 categories: patients who have syndromic obesity and those who have non-syndromic obesity. Syndromic obesities are those rare, classical, heritable genetic conditions with a constellation of dysmorphic features. Often there are neurodevelopmental abnormalities with obesity of one of the many features, the Prader-Willi syndrome and Bardet-Biedl syndrome. Non-syndromic obesity, on the other hand, are patients who have obesity as a predominant and often the sole discernible phenotype that you see. So the vast majority of patients, again, are patients who have common obesity and of polygenic inheritance, where there are multiple small genes with modest effects on their own, but collectively predispose the patients to obesity. Then, of course, about 5% of our population might have what you call monogenic obesity, like the MC4R mutation, where the single gene predisposes the patients to obesity and is of high or full penetrance. Now, of course, there's also a small group of patients where in between, where it's oligogenic, there are a few genes that confer significant risk, predisposes to obesity, and of course, there's a lower penetrance compared to those with monogenic obesity. So these are patients with syndromic as well as monogenic forms on the table here. For the syndromic patients, you can see there's a variable phenotype, many different features. I can't remember all of them myself, but there's some commonality across them: short stature, hypogonadism, and intellectual disability. So I use this red flag for myself. If the patient is short, if there's pubertal delay or hypogonadism, developmental delay, neurological signs and symptoms, abnormal vision, dysmorphism, and consanguinity, you ring the warning bell for me. For monogenic obesity, again, to see that these patients generally have accelerated or normal linear growth pattern. So the red flags for this condition will include extreme obesity by the age of 2 or 3. If there's pubertal delay or hypogonadism, we think of possible leptin deficiency. If there's hypocortisolism, think of POMC deficiency or PCKS1 deficiency, which I'll show you a bit more later on. And of course, if there's consanguinity, do consider possibility of leptin deficiency or leptin receptor deficiency. So the features of syndromic obesity, especially in the patients at a young age, can be subtle and hard to pick up in a busy clinic. Patients with monogenic forms of obesity, like MC4R, may not have specific clinical features which distinguish them from common obesity. But I think this is where the recent advances and increasingly available commercial genetic panels, whole exome sequencing, which are now increasingly affordable, can help us to identify rare, large effect causative variants that results in the obesity. So now a whole monogenic obesity panel now covering 68 genes is only about USD $350. A whole exome sequencing costs now, I think, slightly less than 1,000 US dollars, and the whole genome sequencing is less than 3,000 USD. So this is making it much easier now for us to do the test for the patients. What is the significance of making a genetic diagnosis? First of all, there are some conditions that have specific treatment. The leptin replacement for leptin deficiency can result in a remarkable improvement in the phenotype for the patients here. Patients with pro-opiomineralocortin or POMC deficiency, PCSK1 enzyme deficiency, they may need life-saving steroid replacement because these patients have ACTH deficiency and hypercortisolism. And of course, now there's a new drug that's available for certain syndromic obesity, namely setmelanotide. Setmelanotide is FDA-approved for patients 6 years and older with genetic test confirmed POMC deficiency, PCSK1 deficiency, leptin receptor deficiency, and Bardet-Biedl syndrome. It is an MC4R agonist designed to reestablish the melanocortin pathway activity. It's 8 amino acid cyclic peptide analog of the endogenous alpha-MSH, selectively binds and activates the MC3R and MC4R and the CNS, but also MC1R in the skin. And that's why one of the side effects is actually hyperpigmentation. But fortunately, it does not bind to the MC2R of the adrenals, which might otherwise lead to hypocortisolism. So this is a once-a-day subcutaneous injection, and you increase it in a stepwise manner. The common side effect, as discussed earlier, is darkening of the skin, and nausea, vomit, GI side effects, and also it can cause depression and priapism. So how does it work? So food intake will be stored in the adipose tissue, which will produce leptin, crosses the blood-brain barrier, and then it hones in on the feeding center in the arcuate nucleus. And here it stimulates the melanocortin neurons, which produce POMC, which is processed by PCSK1 to alpha-MSH, and therefore stimulate MC4R receptor downwards to reduce food intake, increase metabolic rate, and MC3R receptors to reduce feed efficiency. So in other words, the melanocortin pathway reduces feeding. And if there's any disruption, and the BBS gene products actually traffic leptin receptors to the surface of the POMC neurons and thereby enable the POMC neurons to react and respond to the leptin. So when there's any disruption to BBS gene products, POMC, PCSK1, you will disrupt the melanocortin pathway and lead to increased feeding. And this is where setmelanotide will step in and fill the gap and re-establish the melanocortin pathway. So here is some data to show you the effectiveness of setmelanotide on weight loss for patients with POMC deficiency and leptin deficiency. So for these patients with POMC deficiency has a 20% reduction in body weight at 1 year, and in leptin deficiency, a 10% reduction in the body weight. And there's a reduction in the hunger score for these patients by about 25 to 50%. And for patients with Bardet-Biedl syndrome, it reduces the body weight by about 9.5% in adults, and BMI Z-score reduction of minus 0.8 for children and teenagers with Bardet-Biedl syndrome. This paper just came off hot on oven at June 2024 in the Lancet Diabetes Endocrinology. Essentially, is explore the use of setmelanotide in patients with hypothalamic obesity, such as those with craniopharyngioma postoperatively. And we know that their obesity can be quite recalcitrant to treatment in many of our experiences. So in about 16 of these patients who had this treatment, the mean reduction in the BMI was about 15%. But in the 12 patients who completed 12 months of therapy, the mean BMI change was an impressive minus 26%. And So do watch this space for further information about the use of setmelanotide in patients with hypothalamic obesity. So our second task for our patient was to diagnose and manage obesity-related complications. There will be a plenary lecture tomorrow on this topic, and so I shall not dwell on it any further, except to highlight to you the various complications that the patient might have, which includes metabolic, mechanical, and psychosocial complications. And actually of note is that psychosocial consequences like depression and poor self-esteem is likely to be more prevalent than any metabolic and mechanical complications, and we should be mindful about this when we see our patients and manage them accordingly. So how and when do we screen them? You probably want to remember these 6 points that will help you, and this is the recommendation from the AAP CPG. So for children who are 10 or above, whether they are obese or overweight, if they are obese, do offer them lipid abnormality screen, glucose screen, and liver function screen. If they are just overweight, you can still offer them a lipid abnormality screen. But if they're overweight with the risk factors for type 2 diabetes mellitus, do check their diabetes status. This includes family history of diabetes, history of gestation diabetes, signs of insulin resistance like acanthosis nigricans, and the use of obesogenic psychotropic medications. And if they're overweight with risk of NAFLD, do then check the LFT. These are patients with family history of NAFLD, again, signs of insulin resistance, or they have pre-diabetes or diabetes, and dyslipidemia and sleep apnea. Do consider screening them for NAFLD. And in children who's 2 to 9 years old, the AAP recommends that you evaluate their lipid profile. So I'm going to move on now to weight management strategies. So when treating childhood obesity, we have to remember what makes the child tick. Ensures a developmentally appropriate approach for the child. You must effect a lifestyle and behavior change. Target these 4 areas: eat healthier, exercise more, less sedentary activities, and sleep better. You can then, where appropriate, consider pharmacotherapy as well as bariatric surgery. I'll cover more about pharmacotherapy in subsequent slides. The next speaker will be speaking of bariatric surgery. I will speak no more on this topic. So just remember a few things. A young child is not motivated. They will be unwilling and couldn't understand why must they change their pleasurable lifestyle, and you need the support of the family. Very often, you have to target and treat the family because often the family also share the same undesirable lifestyle and habits, and they're also often overweight. And parents and the siblings actually act as role models and the change agent for the child, and it will be better motivation for the child if the whole family change the lifestyle and eating habits together. You're only likely to succeed if both the family and child are both ready to change. And of course, try to involve the main caregiver too. The main caregiver might not be the parents, but might be the grandparents or a helper. And some key points again, in a very young child, we will not ask for restrictive diet, but rather instill healthy eating habits, because restrictive diet may impair the growth inadvertently, but restrictive diet may be necessary for the severely obese adolescent. Encourage more physical activity, or rather discourage physical inactivity, reduce the screen time, and increase exercises at least 60 minutes a day. And of course, for the young child, often we aim for slower or no further weight gain instead of weight loss. And at this juncture, I'm going to just share with you some of the recent recommendations from the American Academy of Pediatrics, CPG, for treatment of children and adolescents with obesity. It just came out in year 2023. Essentially, the key recommendations is to instill intensive health behavior and lifestyle treatment, to offer pharmacotherapy early and immediately. And it stressed that there is no benefit to watchful waiting, and we should offer obese adolescents 12 and above weight loss pharmacotherapy as adjunct to health behavior and lifestyle treatment, and we even offer children 8 to 11 years with obesity for weight loss pharmacotherapy. But then a lot of these medications are actually meant for 12 and above, and therefore this use is off-label. And of course, we should offer referral for adolescents 13 and above with severe obesity BMI 120% of the 95th percentile on the CDC BMI chart for evaluation for metabolic and bariatric surgery. And let's talk about the intensive health, behavior, and lifestyle treatment. This is a treatment to educate and support families in nutrition and physical activity changes. Is provided in conjunction with pharmacotherapy and bariatric surgery. They recommend 26 hours or more, best if it is 52 hours or more, face-to-face, family-based, multi-component, over 3 to 12 months. I did a calculation. That means 0.5 to 2 hours per week, or 1 to 4 hours per week of attendance with the healthcare professional. I think even the CPG acknowledges the limitations. There will be significant loss of school or work time for the parents to attend. There will be multiple recurring appointments during what is typically working hours for the parents and school hours for the children. Families will have transportation challenges, especially those who are not well-to-do. And there's a relative scarcity of such programs and trained personnel. And of course, when this CPG was out, it's not well received by the public and the media, and the CPG faces criticism, who calls this CPG aggressive and even terrifying. And of course, the medical fraternity was very worried about this too, because of the costs and the burden on an already strained healthcare system, and also worry about the long-term efficacy of these medications used on the children. But I feel that this CPG does serve a greater purpose. It set the standard, and it challenges healthcare professionals to change our mindset and review our practices to meet our patients' needs. It advocates for resourcing of services and treatment, and of course, lobby for insurance cover. It opens the door and moves the needle. So those who have been practicing at the turn of the century, people of my vintage, will have witnessed the rise and fall of many anti-obesity drugs, like fenfluramine, which can cause heart valve damage, sibutramine, which was promising but resulted in a severe cardiovascular event and it was withdrawn. Then rimonabant, which was again quite promising but resulted in severe adverse side effects and also similarly has to be withdrawn. All these steps have been around for a long time but has many severe many unpleasant GI side effects, and that limits its use in our patients. But in the last 3-4 years, we see a significant rise in a new set of anti-obesity drugs again. And some of them were so outstanding that they've been called the showstopper drugs. And AAP advocated adjunct pharmacotherapy with ongoing lifestyle intervention because many studies have shown that physiological adaptations to weight loss has made it hard to maintain weight loss for these patients because the body will tend to defend its previous weight. But the anti-obesity medications should not be viewed as an easy way out, allowing the individuals to eat ad libitum, but it can help the patients to combat the heightened hunger and craving associated with weight loss and help the individuals to adhere to a healthy lifestyle more readily, especially if there is a health risk present like type 2 diabetes, especially for adolescents with obesity. We all know that it's harder to comply with lifestyle and diet interventions for this group of patients. So here is the list of medications that's FDA approved for children. So here is the list of medications that are approved for children 12 and above. All listed, you can still use them. There's a combination medication, phentermine and topiramate. Kismia is the brand name. There's liraglutide or Saxenda, which is a daily injection. And there is, of course, Wegovy or semaglutide, which is a weekly injection. For patients more than 16, you can use phentermine. I think in some countries, the age might be 12 years. And of course, we just mentioned earlier, set a melanotype for those who are 60 and above with syndromic obesity. In terms of time, I'm just going to cover quickly 3 of the new drugs. So here is phentermine and topiramate or Kismia for the treatment of adolescent obesity. Here is a 1-year study for a group of patients, 100 patients. And here you can see that up to 40% of these patients had 10% or more BMI reduction, and 30% had more than or equal to 15% of BMI reduction at the end of 1 year treatment. And of course, I think all of us are here familiar with GLP-1. So GLP-1 acts on the brain to reduce appetite and increase satiety, increase energy expenditure, and on the gut to reduce gastric emptying and gastric motility. It also helps to improve our insulin sensitivity and insulin production. And it's produced by the L cell of the distal intestine in response to nutrient load. So the analogs are the fashion of the decade. So here is the liraglutide or Saxenda. It's a daily subcutaneous injection, and you increase the dose by 0.6 milligram every week to a maximum of 3 milligram. And here is the study, a 1-year study involving about 250 teenagers with lifestyle therapy in both arms. And we can see from here that compared to the placebo, those on the treatment at end of the year has a reduction in the BMI standard deviation score of 0.22 and a relative change in BMI of 4.6%. And about 26% of the participants with the liraglutide has 10% or more of reduction in the BMI. And this paper literally just came off last month. Liraglutide used in children from 6 to 12 years of age. Just 82 participants with a mean BMI Z-score of 3.72. And we can see again that there was a reduction in the BMI of about minus 2.4 and the change in body weight of minus 8.4 kilogram at the end of 1 year. And the side effect profile looks manageable, mainly GI. And so again, let's see whether they will get the FDA approval for use in children below 12. So semaglutide for use in adolescents, this is FDA approved in 2022. It's a weekly injection. You escalate every month to a maximum dose of 2.4 milligram. And here in this study, we can see there's an impressive 37% of patients who achieve 20% or more of weight loss. And 40% of patients have 20% or more reduction in the BMI at the week 68 of treatment. So this drug was so impressive that it was called the showstopper obesity drug. So when this drug was being used, there were some concerns of reports of suicide ideation. So this is a study, a retrospective study that looked at all the electronic health records, comparing patients who are on semaglutide and those who are on other forms of anti-obesity medications. I think they have concluded that there is no association with elevated risk of suicide ideation, where you can see that the hazard ratio is consistently below 1. So here's a summary slide to show all the medications that is available to us, pediatrician. So in the order of efficacy, so semaglutide is the one that's doing very well, but I don't know about you, it's not available in my country yet. So Kismir as well is not available in my country. Liraglutide is available, phentermine is available, orlistat is available. So those who are precision medicine may be applied to the choice of medications as well. So some people had advocated trying to come up with an obese phenotype for the patients, whether they are patients with a hungry, based on these 7 questions that's listed here, whether they are patients with hungry brain, which is a difficulty with satiation. Satiation is the end of desire to eat during a meal. Whether they are patients with a hungry gut, where they have a lack of satiety, which is the time between meal where one feels full, or whether they are patients with emotional eating, or they are patients who are slow burn, exercise all the time but cannot lose weight. So if the patients with hungry brain can consider using the phentermine, topiramate, or Kismir combination. If they're hungry gut, you can consider GLP-1. If the emotional eating, you can use Contrave, but this will be off-label use because it's not approved yet for patients less than 18. And for patients with slow burn, you can consider phentermine. And of course, you can also be guided by the associated comorbidities of these patients. If they have insulin resistance, pre-diabetes, diabetes, you can consider metformin, GLP-1 agonists. If there's PCOS, consider metformin. If there's any FLD, consider GLP-1 agonists. If there is emotional eating with loss of control and binge eating disorder, you can consider topiramate as well as dexphentamine. And of course, if there's associated depression and anxiety, consider the use of bupropion. So my last slide here, I think, I know this question will come, I must answer them now. Further research is needed. Which order of the various treatments should be offered? Lifestyle therapy first, followed by anti-obesity medications, or the combination from the outset. Which one is practical and which one is will do the best? How long can we and should we treat these children with anti-obesity medications? And for intensive health, behavior, and lifestyle treatment, will virtual consultations be as effective in the place of in-person visits? And with that, I thank you for your attention.
Thank you, Professor Leung, for a very nicely summarized talk on approach to management of obesity in children. We will have questions at the end of the 3 talks. So I would like any questions towards him can be addressed at the end of the 3 talks. Other than obesity, the most recently emerging problem, especially for the pediatric adolescent physician and the pediatric endocrinologist now, especially in India, is the problem of menstrual disorders, essentially with polycystic ovarian disease. Primarily, it was considered to be an area of specialization for pediatric gynecologists, but over and now, more and more pediatricians are being asked to intervene in the management of these children because of the advancement of the years to be managed by pediatricians in many countries. To give us an overview on the topic of adolescent PCOS, I invite Professor Alexia S. Pena. Alexia Pena is Associate Professor from the University of Adelaide and Women's and Children's Hospital of Australia. She has a special interest in the field of obesity, polycystic ovarian syndrome, type 2 diabetes, and also in the field of medical education. Over to Professor Alexia Pena. Am I audible to you, Dr. Alexia?
Yeah, that's okay. There is a pre-recorded presentation.
Yes.
Good morning, everyone. I'm really sorry that due to personal reasons, I'm unable to do this presentation face-to-face. And I hope to be able to answer questions online, and feel free to email me with further questions. I also want to thank the all organizers for inviting me to present on this important topic. I'm originally Colombian, this is the accent, and have been based in South Australia for the last 25 years, the wine state of Australia. These are the topics I'm going to cover today in relation to polycystic ovary syndrome or PCOS. So let's start with PCOS itself. The name of the condition might change in the near future because the name was derived from the appearances of the ovary, but they are not cysts, they are arrested follicles. And not every woman with PCOS have ovaries like the ones shown in these pictures, and adolescents without PCOS might have ovaries like these. And it's also not an ovarian disease. It's also a disease that is associated with some metabolic comorbidities. And the reason mainly for not changing the name is that PCOS has an historic historic traction, and consumers are getting resistant to at least the acronym. So the name might change, but the acronym PCOS will stay. So Professor Helena T. shown on this slide, has a very strong vision with other multiple healthcare professionals to improve assessment and management of polycystic ovary syndrome. And there were 2 guidelines produced, the most recent one in 2023, and guidelines are available in this website. And basically the guidelines start with evidence from research that will include different reviews of the trials or all research available, even including integrity tools. And there were 52 systematic reviews in these evidence-based guidelines. There was clinical expertise from all around the world, including 39 societies. There was some assessment of cost effectiveness, but most important, we had consumer perspective from different PCOS consumer societies around the world. And I was very fortunate to be part of the 2 guidelines. In 2018, and I led the adolescent PCOS recommendation manuscript. And in 2023, I'm currently waiting for the reviews from BNC for this publication of the current guidelines. So let's start what is the criteria for PCOS in adolescents. The first criteria is irregular menstrual cycles or ovarian dysfunction according to time of menarche. But take into account or considerations that mean age of menarche is different across different populations. So the definitions of irregular cycles according to menarche are less than 1 year post-menarche, the irregular cycles are part of the normal pubertal transition. Between 1 and 3 years, the irregular cycles are the ones that are less than 21 or higher than 45 days. If you are higher than 3 years post-menarche, cycles less than 21 days or higher than 35 days or less than 8 cycles per year are irregular and abnormal. But if more than 1 year post-menarche, any cycle higher than 90 days is abnormal, and you usually ask the patients about the longest gap, that is more likely that they remember instead of having exact detail of the number of days. And primary amenorrhea is important to note. About 30% of adolescents with PCOS present with these features. So primary amenorrhea by the age of 15 or according to your population or higher than 3 years post-menarche or breast development. The second criteria is hyperandrogenism, that is clinical or biochemical. For clinical hyperandrogenism in adolescents, it's important to know one of them is severe acne, as a lot of adolescents have peak of mild acne at about 15 years of age. But severe acne, as shown in the graph on the bottom, does not increase markedly post-menarche. But it's the acne that has higher number of inflammatory lesions, resistance to scars, to treatment with scars, and is not common in adolescents. The other sign of clinical hyperandrogenism is hirsutism that can be evaluated by the modifying Ferrigan-Gellwith score in 9 areas of note, is not including the forearm and the lower leg. These 9 areas are shown in the picture at the top and with some photos at the bottom. The score goes from 0 to 4 according to how much hair, but it's important to note the hair needs to be terminal hair, more than 5 millimeters, and thick black hair compared to the vellus hair. And it's important to know that adolescents should be asked about waxing or hair reduction methods. For example, shaving is 5 days affecting the score, and laser can be up to 3 months. And scores higher than 4 to 6 will be abnormal and considered hirsutism. Hirsutism can also be evaluated by total and free testosterone levels. And if testosterone is not elevated, you can do androstenedione or the hydroepiandrosterone sulfide, but those two are less specific, while testosterone and free testosterone level, even with free androgen index, have a higher sensitivity and specificity around 80% to evaluate hyperandrogenism in adolescents with PCOS. It's also important to note that androgen levels reach adult ranges at about 12 to 15 years of age, and very high levels need further evaluation of other conditions, for example, a non-classical adrenal hyperplasia requiring a 17-hydroxyprogesterone. And also, reliable measure of androgens is not possible in women on a hormonal contraception, and they need a minimum of 3 months withdrawal for this assessment. The investigations that are not recommended in adolescents are pelvic ultrasound, and it should not be used for the PCOS diagnosis in less than 8 years post-menarche. And the evidence comes from 4 adolescent studies that highlight there's no definite criteria. The normative data show rapid increase in ovarian volume and follicles during adolescence that are not necessarily PCOS. And there are issues with adolescent studies, such as the use of transabdominal transrectal ultrasound, and unable to clearly define the volumes and the follicles specifically. And some of these studies have used the Rotterdam criteria to define the population evaluated. It is also notable that a lot of adolescent girls, as is shown in this figure, between 1 and 3 years post-menarche on the x-axis, don't have a normal ovarian morphology, only 30%, and that increased to close to 70 or more than 70% higher than 7 years post-menarche. And this is in the white bars. But if you look at the gray bars on adolescents who have polycystic ovarian morphology but don't have PCOS, so it's up to 60% 1 to 3 years post-menarche, comparing to less than 7% higher than 5 years post-menarche. Other investigations not recommended during adolescence is the anti-Mullerian hormone. The evidence comes from 11 studies in adolescents. There is not sensitive and specific enough to be able to be facilitated in the diagnosis. And this study that we have done cross-sectionally in adolescents with PCOS in purple, comparing to healthy controls in blue, and left total AMH and pro-AMH on the right, showed a lot of overlap around 10 to 20 years of age in healthy adolescents and control. So unable to use the AMH during this time or adolescence. So here is the summary of the PCOS diagnosis during adolescence. So you start with menarche, and first years post-menarche, you are unable to diagnose PCOS because we know the irregular cycles are part of the normal pubertal development. Between 1 and 3 years, you are able to diagnose PCOS after exclusion of other etiologies if you have irregular cycles higher than 90 days, menstrual cycles less than 21 or higher than 45 days, and you have hyperandrogenism, clinical or biochemical. And if you have an adolescent higher than 3 years post-menarche and until 19 years, you are able to diagnose PCOS if there are irregular cycles less than 21 and higher than 35 days, on less than 8 a year, and hyperandrogenism, clinical and or biochemical. But do not use pelvic ultrasound for diagnosis in PCOS in adolescents, and do not use AMH. So in contrast, and here's the summary of the PCOS diagnosis criteria in adults and adolescents according to the recent guidelines. So in blue, we got the adult criteria that require 2 of the 3 features: oligoanovulation, clinical biochemical hyperandrogenism, and polycystic ovaries and or anti-Mullerian hormones after exclusion of other criteria. Was adolescents in pink require only 2 criteria: oligoanovulation, irregular cycles, and hyperandrogenism after exclusion of other criteria. The criteria for adults used to be called Rotterdam, but now it's firmly grounded as best evidence. Now moving on to accurate and timely diagnosis. It is important to know that overdiagnosis can be found if you use polycystic ovarian morphology, and 9% with a 9% prevalence according to a recent systematic review including 20 studies with diagnosed with adolescent PCOS with Rotterdam criteria. compared to a lower prevalence 6.3% using the international evidence-based criteria, regular cycles and hyperandrogenism. It's important to know there is higher prevalence in Southeast Asia and here in India, irrespective of PCOS diagnosis criteria used. So we got on the left the international PCOS guideline showing at the bottom higher prevalence for studies coming from adolescents in India. And on the right-hand side, the Rotterdam criteria used for adolescents with PCOS. And at the top, we have higher prevalence in this forest plot for PCOS in India comparing to other regions around the world. It's also important that timely diagnosis allows the early screening of comorbidities, especially glucose abnormalities. And in this systematic review, including 6 studies in adolescents with PCOS who had evaluation of glucose abnormalities, there was a 4-fold increase in the risk of development impaired glucose tolerance comparing to controls. But there was no difference for type 2 diabetes, impaired fasting glucose, or pre-diabetes. It's important to know the impaired glucose tolerance needs to be screened, and this is confirmed in adult women's studies as well, and it's confirmed for type 2 diabetes in a larger population, women with PCOS. The timely diagnosis allows also early screening of psychological comorbidities such as depression, and this systematic review and meta-analysis had shown that adolescents with PCOS had a 2-fold increased risk of depression, and it needs evaluation once you get the diagnosis of PCOS. The other comorbidities, psychological comorbidities such as anxiety, in the current meta-analysis with 3 studies did not show any difference between adolescents with PCOS and adolescents without PCOS. But of note, there's smaller studies and there's a high data or evidence for adult women with PCOS with high risk of anxiety. And we have shown in a cohort of 89 adolescents with PCOS, a study done by one of the psychiatric registrar at our hospital, showing that adolescents with PCOS had high levels of moderate to severe, extremely severe depression, anxiety, and stress, according to the Depression, Anxiety, and Stress DAS-21 score. There's also other comorbidities that can be able to be diagnosed or evaluated with a timely diagnosis, and this is eating disorders and food body image. So far, there's limited data on adolescents, but there is a lot of data in adult women, and we know that adolescents without PCOS have a high prevalence of eating disorder and food body image. This is on the right, one of the brochures that can be used for education about emotional well-being in adolescents. And it's important because adolescents are not satisfied with information given a diagnosis in relation to emotional support and counseling, according to this cross-sectional study, qualitative study. The other importance of timely and accurate diagnosis of PCOS during adolescence is avoid missing the opportunity to intervene early in a high-risk group of long-term weight gain. So in here, this graph, we got on x-axis, the age in years, y-axis, the BMI, and this is data from the RAIN population study in Western Australia. So as we see in red is the cohort of who was diagnosed with PCOS, and around 12-13 years of age, this group of adolescents have a marked increased weight gain up until the last follow-up around 22 years of age, comparing to the non-PCOS group in green, or the groups that were found to have oligomenorrhea and PCOS morphology, or hyperandrogenism and PCOS morphology alone. Additionally, difficulty losing weight and weight gain are in the top features of PCOS that are most important to adolescents with PCOS, as shown in this graph. So what happens if you have features of PCOS as discussed but do not meet the diagnostic criteria. These adolescents should be considered at risk of PCOS, and these include isolated menstrual irregularities but no hyperandrogenism, hyperandrogenism and irregular menstrual cycles, or hyperandrogenism and menstrual irregularities in the first years post-menarche, or hyperandrogenism and menstrual irregularities 21 to 45-day cycles 1 to 3 years post-menarche, or metabolic syndrome and menstrual irregularities. The importance of identifying these adolescents is that they require follow-up, and a healthy lifestyle should be recommended. And the follow-up is just to ensure or reassess the possibility of PCOS at or before 8 years post-menarche. Additionally, these adolescents have been found to have higher mean blood pressure, fasting triglycerides, fasting insulin, HOMA, insulin-resistant LH/FSH ratio, despite having the same weight and BMI in the healthy controls, and about 90% were not overweight or obese. So irrespective, they are at a higher metabolic risk comparing to healthy controls, so they need to be identified. And this is according to a recent study from Korea. Now let's move into the treatment of this adolescent, and this is one of the brochures that came off the guidelines that is available from the Monash PCOS guidelines site. So we got a management, and the first thing to do with adolescents is appropriately timely diagnosis. Are we dealing with PCOS or are we at risk? To educate them appropriately about the condition or the need to follow up. The shared decision-making, parents, families, adolescents themselves, and the healthcare professional. Teaching and encouraging healthy lifestyle to avoid weight gain or reduce weight. Screening for glucose abnormalities and depression. And very important, treatment to symptoms. Either you have PCOS or at risk, they come to you to assess abnormalities that are impacting on the quality of life. In adolescence, it's very important to ensure the follow-up and transition. So let's start with the combined oral contraceptive pill. It is used for management of hirsutism and cycles in adolescents at risk or PCOS, and this is based on 10 randomized controlled trials in 420 adolescents with PCOS. Should be starting with a low-dose pill, and the second line should be 35-ethinyl estradiol prostacyclopyrrone acetate, taking into account the benefits and side effects being a thromboembolic risk. There's also a possibility of progestin-only pills, but for endometrial protection, but the evidence in women with PCOS is limited, and there is no evidence in adolescents. And this is data from a systematic review and meta-analysis, especially in relation to the pill, a combined pill, and the references listed in there. The combined oral contraceptive pill could be used over metformin for management of hirsutism and irregular cycles, and metformin could be used over the pill for metabolic indications in PCOS. Combination offer a little bit or additional benefit over metformin of the pill or metformin alone, but with limited adolescent data. If we think about metformin itself, it can help for hirsutism and irregular cycles with 4 randomized controlled trials, 142 adolescents. And again, the combination offers little or additional benefit over the pill or metformin alone. They should be titrated slowly up to 2 grams in adolescents, and the size and the preparation XR are important to decrease side effects or improve adherence. This is again according to another systematic review part of the guidelines. For anti-androgens, in combination with effective contraception to avoid abnormalities in unborn fetus, and it could be considered to treat hirsutism in women with PCOS if there is suboptimal response after 6 months of the pill and or cosmetic therapy. Spironolactone is the most used with 25 to 100 milligrams a day, with lower risk and adverse effects. The trials that were evaluated in adolescents in this systematic review were two, and they were mainly combinations of Spiomed, spironolactone, pioglitazone, and metformin, and mainly studies coming from Spain. There is a current multi-center study going on in Europe with this medication. In relation to the anti-obesity medications glucagon-like peptide-1 receptor, the trials are mainly in adult women, and they've shown effects on weight and insulin as the mechanism of action of this medication, but there is no effect on PCOS symptoms and no data in adolescents. And inositol is a supplement with multiple preparations widely available that has some effect on insulin resistance. There are specific types, doses, and combinations cannot be currently recommended in adults or adolescents with PCOS due to the lack of quality evidence. There is a suggestion that, as I say, improve insulin resistance with less side effects of metformin, but metformin should be considered over inositol for treatment of PCOS, and this is according to another systematic review and meta-analysis. There are no studies in adolescents, and we will require more evidence. The only issue is that there were issues with integrity in the trials published for inositol. So let's move into cosmetic therapies or mechanical laser light therapies for hair reduction. There are mainly studies in adult women, and it's shown that mechanical laser light therapies alone or in combination with other agents reduce facial hirsutism, but no studies in adolescents. And there might be some indication in improving quality of life that is affecting these women with hirsutism. Transition, last but not least, there is limited data evaluating transition in PCOS, and transition is required not only for adolescents with PCOS, but at risk for reevaluation at an appropriate time to review for PCOS diagnosis and management, and should include a multiple healthcare professional with patient-centered approach and a general practitioner at front. So in summary, the management should be according to symptoms in adolescents with or at risk of PCOS, starting with a multi-component healthy lifestyle. And for menstrual cycle irregularity, use the pill or medroxyprogesterone every 3 months. And can be monitored cycles. Not everyone needs to be on the pill. If they have every cycle every 2 months, as long as they are happy with the irregularity of the cycles. And primary amenorrhea, they should be treated with medroxyprogesterone acetate to cause a window of breathing before deciding on the pill. For hyperandrogenism, severe acne, appropriate skin care is required for the severe acne. Topicals such as Epiduo-Gel on benzoyl peroxidase, systemic antibiotics, and the pill or dermatology referral. And for hirsutism, cosmetic therapy, the pill, anti-androgens. And for weight or hormonal comorbidities, metformin and reinforcement of healthy lifestyle. In summary, for diagnosis of PCOS in adolescents, the condition needs accurate and timely diagnosis and management of PCOS and PCOS adolescents at risk. And adolescents need different PCOS criteria comparing to adults, and that includes irregular menstrual cycles in relation to menarche and hyperandrogenism after exclusion of other medical conditions. Do not use pelvic ultrasound or AMH. And adolescents who have features of PCOS but do not meet the diagnostic criteria should be considered at risk and require follow-up and management. And last summary for the management should include education, lifelong healthy lifestyle interventions, weight management, prevention of weight gain, medication according to symptoms, awareness, screening, and intervention for glucose abnormalities, depression, and other risks. Cosmetic therapy, laser should be offered, longitudinal follow-up for diagnosis, management, and transition. And the evidence overall in adolescents is limited, low to moderate quality, and a lot of further research should occur in this group. And last, acknowledging the international PCOS network I have been part of with Professor Helena Tidi leading and Professor Rob Norman. Thank you very much.
Thank you, Prof. Alexia Penna, for the excellent talk. She will be here at the end of the session to answer the questions, so reserve the question till the end. So let's allow me to introduce our last speaker for this symposium, Prof. Kenneth Ka Yuen Wong. He is the clinical professor and the chief of division of pediatric surgery from University of Hong Kong. He set up the pediatric robotic surgery and introduced single port surgery, bariatric surgery, and thoracoscopic surgery. His area of interest are neonatal surgery, advanced laparoscopic robotic surgery, and gastrointestinal and thoracic surgery. He is also the editor to various pediatric surgery journals with multiple publications and research work. His CVs are extensive, so I don't have time to go through them all. So the title of the talk that Prof will be delivering to us is Surgical Treatment in Children with Obesity. So with that, Prof, the floor is yours.
Thank you, chairpersons. First of all, I'd like to thank the organizers for inviting me to come to India, although it's not a very long way from Hong Kong, it's still a 5-hour flight. I'm sure all of you know coming to India is a bit of a difficulty getting visas, so eventually I came. Looking around the meeting hall here, I'm probably the only surgeon around, so I feel like really a square peg in round hole. But anyway, I try to share my experience. Oh, one more surgeon, 2 of us. So I just want to share my experience in dealing with obese children, and some of my slides and papers I'm going to cite here in my talk have probably been covered by Professor Lee here previously. So don't feel to get bored. So first slide is no conflict of interest. I'm not paid by anyone or any company for my talk here. So we're going to ask, the first question is, what really is the scale of the problem? So this is a map. I think the origin of obesity probably starts from the United States years and years ago. It's been spreading around the world since then. Look at the map of adult obesity in 2011 in the USA, and you can see that actually it was quite prevalent. The green state of California, which is circled here, even that was green, and the healthy state of the United States, of all the 50 states in the country, the prevalence is still around 20-25% of all the state population in California. So it's still quite significant. But taking this back further on 10 years, comparing this to 2021, even the California state is turned from green to yellow, which means that the prevalence of obesity in adults is around 30%. But more significantly, if you look at Kentucky or West Virginia, they are the worst. Up to 45% of population is obese in adults, at least. So estimated annual medical cost of obesity in USA alone is $147 billion, which is a vast amount of money spent. So what about the kids in adolescent? It's a similar problem in the States. Although it's not as severe as adults, it is still pretty horrible looking. You look at the curve growing significantly in the States. I'm not sure what exactly the reasons are, and maybe it's the size of the portion of the food is too much in the States, or whether they spend too much time looking at Google and playing games at home. Nobody really knows. But as I said, the problem has been spreading around the world from the States ever since then. And in Hong Kong, as similar to all Asian countries, the prevalence of obesity is actually not as severe as USA, but even so in Hong Kong, if you look at the prevalence from 2011 to 2020, it's been steadily increasing at a slower rate. So the overall prevalence is around 20% of all children in adolescence will have some sort of obesity. I don't want to tell you the definition of obesity because all of you in the hall would be experts in seeing children. But significantly, a lot of patients that I see in my clinic are those referred for severe obesity and morbidly obese as well. But why should we really care? Because obviously, in Hong Kong, 1 in 5 children are obese, and they can have the same comorbidities as obese adults. For example, hypertension, type 2 diabetes, obstructive sleep apnea, gastric reflux, liver fibrosis, and even orthopedic diseases. So if these are untreated long-term, then you expect these children with a shorter lifespan than usual. Not only are they physically affected, psychologically, they are affected as well. And this paper, published only last year, described the life course of obese children and the risk of having depression and anxiety when they become middle-aged people. So obesity is a big problem, not only in physical sense, but also in psychological sense. This is a paper quoted by Professor Lee earlier that the AAP now recommends proactive and intentional screening of all pediatric patients using BMI to screen and diagnose for overweight and obesity, and systematic screening of risk factors such as family history, racial identity, adverse childhood experiences, and income status. So we want to find out who these people are, who these children are, and try to treat them proactively rather than sitting and wait. There's no point in watchful waiting anymore. What are the management options if you're going to treat these children? Obviously, you can treat them non-surgically using dietary control, using medications, or surgically, whether it be putting a balloon in the stomach or using severe form of surgery like lap band, sleeve gastrectomy, or even bypass surgery, such as Roux-en-Y gastric bypass or duodenal switch. So the question I really had to ask myself is surgery a better management option for these obese adolescents? This was a paper published not so long ago, a few years back, from a group in UK, showing that very clearly, comparing non-surgical treatment group and the surgical treatment group, there is a vast difference in terms of the weight loss outcome. So to me, very clearly from this graph, surgical option is probably better than non-surgical treatment. So what are the options? When I first started dealing with these kids, I tried to put in balloons, intragastric balloons in these kids. The top photograph here showing you a balloon being put in there for some, many months, and it's turned a bit of blackish in color and horrible looking. More recently, the balloons can be swallowed by patients, and once it's been swallowed into the stomach, you can inflate via a little channel connected to the balloon and into a large size of 4 liters. And then it can occupy the space, and hopefully patients can feel full all the time and they don't eat as much. But probably the most important problem with putting in the balloon is that many patients will describe to me that they feel very uncomfortable, feeling a big sort of bag of fluid sitting in the stomach. When they walk around, they don't feel very comfortable at all. And the weight loss rate is very, very slow. And the weight loss achieved is not as significant for morbidly obese children, of around only 5%. So very quickly, that has shown to me that putting in a balloon is not a solution. What about other surgical options? Lap band, putting a band at the esophageal gastric junction to control the inflow of food into the stomach, used to be a fashion about 15 years ago. But now, because of the severe issue with complications such as erosion into the esophagus, bleeding perforation, then it is really fallen out of fashion. And also, the weight loss outcome for lap bands, which is up here, is not as significant as sleeve gastrectomies or Roux-en-Y gastric bypass. So nowadays, lap bands probably not being done anymore. So the only two well-documented surgical options are really the gastric bypass, which would create a small gastric pouch, followed by a bypass using a gastrojejunostomy to create a very restrictive and small stomach and leading to malabsorptive of nutrients. And in severe scenarios, some patients can achieve around 60% weight loss. But the problem is this operation is technically more complex. It requires resection of the stomach. It requires anastomosis, rejoining of the small bowel to the stomach. And the long-term nutritional deficiency, such as vitamin and mineral, are quite significant as well. Whereas if you look at sleeve gastrectomy as a whole, all you need to do is to resect around 80% of the stomach, leading to a restrictive kind of weight loss. There's no joining of small bowel to the stomach. It's technically easier. And although some papers have described some vitamin deficiencies in these kids, actually it's very, very low risk. So compared to Roux-en-Y gastrectomy, Roux-en-Y bypass, sleeve gastrectomy is actually a more acceptable, much easier, and much better option, to me at least, for obese children. So if we look at this paper published by Tom Inch in the States, you can see very clearly that the current trend of surgical option is really sleeve gastrectomy. It's now taken over as the majority of all cases being done in the States and probably in the world as well for surgical management of obesity. So taking this together, if you look at the weight loss outcome 3 years after surgery for obesity, it is actually very impressive. Not only do we achieve weight loss, which was the original aim for the operation at the very beginning, now that we've done many research in the world, that we know that even the comorbidities such as cardiovascular risk and type 2 diabetes can be cured by surgery. So if you look at the graph on the left-hand side, those in the blue are those who have had surgical management of obesity. You can see that the risk of cardiovascular events have been reduced dramatically after surgery. Correspondingly, if you look at type 2 diabetes, you look at this bit here, the rate of normalization of HbA1 before and after surgery is very impressive as well. Before surgery and after surgery, after 6 months alone, the HbA1 normalization has gone up to 80%. I'm just going to show you, this is a real-time operation that I do on one of my patients. I can assure you it's not very bloody. So if you're not a surgeon, so you don't need to faint either. So this is a patient who was a 16-year-old with a BMI of 44 and a body weight of 140 kilograms. So this is a very large stomach from years of overeating. And what we're going to do is to measure the distance between the pylorus and the location where we want to do start doing the stapling of the stomach. So as I said, this is a live recording, so I haven't speeded it up, so you can see how simple the operation is. So we're going to divide the blood supply to the greater curvature of the stomach and all the way up to the gastroesophageal junction. So once we devascularize the greater curvature, we're going to put in a stapler. So with this stapler, the job of us doing this gastrectomy is much more simple and much easier. We're going to create an eventual gastric tube for the patient, leaving a very small stomach. So this is all battery-powered stapler. So all the way up. I see nobody's fainted yet. And once we've done this, we're going to reinforce the staple line with a row of sutures so to make sure that the risk of leakage from the staple line is minimized. Okay. So I'm not going to show you anymore because it's basically that's all there is to sleeve gastrectomy. So it's a very simple operation. You can see that I've shown this video for just over 3 minutes, and in fact, from the whole operation takes about half an hour only. So it's very simple, very easy operation, and achieve a lot of good things for our patients. So the patient can eat on day 1 and can be discharged home on day 2 after surgery. So very quick procedure, very short hospital stay, and with minimal complications. So the question for all operations that we do is the surgery safe? You can see that on the circle, the sleeve gastrectomy has got very low complications, 0 mortality and very low complication rate. And even if they have complications, they are very minor complications, only like small wound infections. Any growth concerns? The quick answer is no. There's no data to suggest that pubertal growth is affected by our surgery. And therefore, there's no reasonable argument to limit access to surgery in adolescents to help them to achieve weight loss. Now, who is the candidate for surgery? This is a paper published in 2018 from the from American Society of Metabolic Surgeons. So BMI over 35 with clinically significant comorbidities, or those with BMI over 40. And this is basically the same guideline as in adults. So those were 2018, the guidelines 2018. And also in the last sentence here, that the guideline says we have to ask a psychiatrist or clinical psychologist to assess these kids whether they're ready, the family ready or not to accept surgery. This was a guideline 2018. So the benefits identified in 2018 guidelines was 1 year reduction of the metabolic syndrome of between 50 to 100%. Over the course of 5 to 12 years, remission rate of type 2 diabetes is 88%, very impressive. And the result is much better and longer lasting than seen in adult literature. A new guideline came out 2 years ago. And basically, for adults, this is adults, okay, the society recommended BMI of over 35 regardless of presence and absence of comorbidity. So they lowered the BMI of 40 in adults to 35 now. And the 35 with one comorbidity has now been lowered to 30 for adults. And also they recognize that clinical obesity, the BMI for Asians is actually lower. So the BMI criteria for Asians should be lowered as well. But having said that, for the same guideline for children, it's pretty much the same as the 2018 guidelines, except that syndromic obesity, development delay, autism spectrum, other things which are not primary idiopathic obesity, they should be also considered for possibility of surgery as well. And younger age now also not considered as a contraindication for surgery. I've established a clinic to see these patients with my core team members of 2 pediatric endocrinologists, a physiotherapist, and a dietitian. We see this clinic, we do this clinic once every 3 months. And basically, we have about 10 to 12 patients for each clinic. And we also have now bought a FibroScan for assessment of fatty liver as well. And so we accept new referrals from whole population of Hong Kong and from the age of 12 to 18. And we will follow these patients up until 21. We'll see all referrals, and patients and parents are not rejecting this option of surgery will be considered for surgery as well. So we basically, the only criteria we consider surgery is that they attend 3 clinic visits within 12 months to make sure they have the motivation to lose weight. They haven't gone up in weight over the course of 12 months. And I do not refer my patients for psychological assessment anymore, because if they come to the clinic 3 times in a year and not having gained weight again, then it shows to me that they are ready for surgery. So the average patient BMI in my clinic is 41. So it's pretty high for Hong Kong. We also bring it back to the chart I showed you before. And if you look at the population of patients who have undergone surgery to lose weight, we can classify or divide this group of patients into 2 groups. Those who maintain the weight loss and those who regain the weight after surgery. And what is the difference? The difference is if you do the surgery for those morbidly obese in the beginning, they are more likely to regain weight after surgery. So meaning that you probably should catch them and do surgery on them much earlier before they become morbidly obese. And also, because of a significant proportion of patients also regain weight after surgery, what's another option? Should we redo surgery? It is a possibility. But this paper has shown you that if you give these patients GLP-1 after surgery as well, it will also help them to maintain the weight if they start regaining weight, which is an option. Which has been shown also, GLP-1 is safe in children. Once a week, semaglutide is very effective in maintaining or helping the combination of surgery and injection together to achieve around 25% weight loss, maintained at 3 years post-op. So our current practice is to offer surgery and also GLP-1 post-operatively. I know that Singapore doesn't have it, we have in Hong Kong, so we have the power to give these injections once a week. As I said, average weight loss around 23 to 25% around 2 years. And the main message is early referral is very important. The early refer with the lower BMI, the early do surgery, the less likely they're going to regain weight after surgery. So the summary is patients with lower referral BMI are more likely to maintain normal BMI post-operatively. And when metabolic surgery is performed at a younger age, there's an improved rate of resolution of comorbidities, especially type 2 diabetes. And also there's greater reduction in total weight loss. So early resolution of comorbidities can help prevent long-term effects from chronic illness. And also, these patients will experience significant improvement in quality of life and psychosocial well-being as well. So with this, I end my talk, and thank you very much. If anyone in the audience would like to contact me, there's my email up there. Thank you very much.
Thank you, Professor Kenneth Kak, for beautifully showing us the second option for morbidly obese children. And it is becoming increasingly practiced now, especially in certain parts of South Asia and also in the Middle East. I find more younger children are being more children with morbid obesity with a metabolic background are being taken up for surgery, but still controversy is still there as to who are the best options for children to be selected for a surgery in this particular case. Thank you for your presentations. You have announcements?
No, we'll take the questions now, sir.
Okay. I hope, Dr. Alexia, are you, you can hear the, yeah. Oh, yes. There is a big line, please. Be short and sweet.
Thank you so much for all the wonderful lectures. This question is for Dr. Alexia Pina. You had suggested pioglitazone being a part of the study from Europe as a part of the SPIOMET tablets. What about the effects on bone resorption which increases with pioglitazone? And these are growing teenagers. And my next question is also to who would you recommend should be screened for non-classic CAH, vis-a-vis being a PCOS?
Thank you for your question. Hope you can hear me okay.
Yeah, we can. Thank you.
Now, in relation to pioglitazone, now the trials that have been published in SPIOMET are very limited. We don't have long-term data to assess anything on bone. There is a little bit of concerns about using this insulin sensitizer because of other long-term effects, not only on bone. So until we have results for the larger trial, I will not encourage. I think it's limited to Spain anyway. But the other issue is that why we need to use an anti-androgen on these girls as well. We need contraception. So even if you use a smaller dose, so that's in relation to the SPIOMET and in relation to the screening. It is a good question, and the reality is if there are clinical features suspicious or there are consanguinity in the parents or you have a very high testosterone level, you definitely need a 17-hydroxyprogesterone. But with low threshold, especially in those groups that are high risk.
Thank you so much.
And of course, if it's high, then you just go into the synactin test and confirm.
Thank you so much.
Hi, thank you. My question is to Yong Seng, but to others if they want. I think one of the issues that we've had with obesity for many years is a lack of recognition, both by families and by primary healthcare professionals. If you don't recognize it, you can't treat it. My question for you, Yong Seng, is how much of that is an issue in the Asia Pacific region and certainly around Singapore and your area? And do you have any ways of improving that recognition or that ability? Because you can't treat unless you recognize you're overweight.
Okay, yeah, thanks. Right, I think, first of all, I think there is increasing awareness among the healthcare professionals. It's just whether you want to deal with it in your busy clinic. Many times, these kids do not come to us telling you, I'm overweight, please help me. But they come and see you, I have a fever today or I have a cough. But incidentally, you notice that he is overweight or obese. I think we should take it upon ourselves to actually proactively address them and arrange to see them again. So I think this is what we can do as a community. The second thing is from the public health perspective. And in Singapore specifically, we have the school health system. So I'm sure there's many such systems in your countries as well. So the school health system, one of the priority of our school health system was obesity. because cardiovascular metabolic adverse outcome is the number one killer in Singapore now. Yeah. So I think they're worried about the future. So there's a proactive school-based screening program as well, and many of these kids were actually asked to come. Those who needed tertiary care or specialist care, they will come to our hospital, to the various hospitals for management further. So I think multi-pronged approach. Yeah, but I think we should keep fighting on. I hope that answered the question. Thank you.
Wonderful talk. I have
First preference to the lady at the back, at the mic. Dr. Leena?
Yeah, thank you so much. This is regarding the bariatric surgery. How young are the adolescents or children that you have operated upon? And do you see any difference in how young the children are in the terms of results?
Thank you for the question. My clinic accepts patients starting from the age of 12. Any younger, I know that a lot of Middle Eastern surgeons, they do surgery for younger children as well, much younger, as young as 6 years old. But from my perspective, I think my cutoff point is 12 years old or above. And certainly, as I said in my talk, the earlier or they are the more likely to have a lower BMI and more likely going to achieve better outcome for these patients. But interestingly, if they come in with the parents, and if the parents are obese as well, then I know the outcome is not going to be very good because the parents are the same as the kid. But if the parents are thin and the kid is obese, then the outcome is going to be very, very good.
so I have two questions, one for Professor Lee and one for Alexa. So, presently with obesity, so much obesity, we have also a lot of obesity in India. So the bone age is always advanced in these patients. All your guidelines on basis of age is on the basis of age, age more than 10 years should be always that. Should these guidelines be based on bone age or should be based on the age? So because bone age is always advanced in these kids.
Right. Good question. I think most of the studies on which these guidelines were designed were based on the chronological age of the patient. So I think we should just base it on the age of the patient. I'm sure the studies would have then taken into account the slightly advanced bone age of these patients. I don't think there's a need to use bone age as to adjust for the bone age of the patient for the treatment. Thank you.
Professor Alexa, one question. Most of the girls are having early puberty now. Early puberty is very commonly seen now, especially in our country. And the definition of this, the onset of menarche at this sense. So the girls who are having normal onset of puberty versus early puberty, the definition remains the same for the, for the menarche. The definition, just started menarche, then 1 year after menarche, 2 years after menarche, 3 years after menarche. Does it remain the same for normal puberty onset and the early puberty onset?
Yes, it is, because this is the time when you expect the maturation of the hypothalamic pituitary ovary axis, and that's how you just should be treated anyway. We do see these girls who are obese, who have a high or who have started menarche early, so this will apply for them.
So is there any GnRH causing with these injection GnRH leading to PCOS in the future? Do you have any idea of this or any studies on this? The role of GnR agonist causing future girls who have PCOS?
Now, there is a study done looking into follow-up of children who were treated with precocious puberty in relation to development PCOS, and it was negative, didn't find any correlation.
Okay, last question, please.
My question is Dr. Lee. Children with non-syndromic obesities are not homogeneous. One type might be born as IUGR. The second type might be born as normal weight, and the third type might be born as overweight. Is there any difference in anthropometry as far as their obesity indicators are concerned? And is there any difference? Should we consider this weight while choosing different anti-obesity drugs? And is there any difference in outcome and morbidity as an adolescent?
Thank you. Yeah, so I think the the DOHAT studies in the last 10 years have shown us, more than 10 years, sorry, have shown that as the ex-IUGR babies, when they grow up, they have much higher risk of cardiovascular and metabolic problems. And so for the same BMI between a non-IUGR and IUGR, ex-IUGR and non-IUGR individuals, the one who's ex-IUGR has a much higher risk of adverse outcome. So I agree with you that for those who are born IUGR, you may want to have a lower threshold to embark on pharmacotherapy and of course closer monitoring for adverse outcomes and checking for comorbidities. Yeah.
Is there any difference in height?
Sir, I think we can
Yeah,
continue
I
with
think
this
we
later.
have to stop.
Yes, we are
Difference in height.
Yeah, you may approach the speakers
Yes,
after this. Yeah.
So thank you, all of you. Especially, I would like to thank the speakers and the chairpersons for such an extensive talk on obesity. May I request all of you to please proceed for the felicitation? Can I please invite Dr. Anna Simon and Dr. Anuradha Khadilkar ma'am, please to felicitate our speakers and chairpersons. Dr. Divya will be escorting you to the area we're doing the... And we'll move on to the next session now. Thank you all.